Hello, my dear audience, and welcome to another episode of Let's Talk Micro. I am so happy that you are here. And if this is your first time listening, welcome. Happy that you chose this podcast. And if you're tuning in because you want to hear about this outbreak detection system, this is definitely the episode for you, and we're going to jump on it. But in the episode, I am joined by Dr. Alex Sundermann, and he was a guest before in the podcast, and he joins us to talk about an outbreak detection system that was developed by him and his group at the University of Pittsburgh Medical Center. And he's going to talk about the whole process and how can this, be a potential application, right, for all the laboratories and all the major outcomes of something like this. So let's go ahead and listen to it. Okay, so today we're here to talk about an outbreak detection system and go over some things, like outbreak challenges. And I thought, I saw this article, which is titled Real Time Genomic Surveillance for Enhanced Healthcare Outbreak Detection and Control, Clinical and Economic Impact. And this was published in the Journal of Clinical Infectious Diseases on April 30th. And I'll put that on the show notes. But with me today, I have a guest, and he's been here before on the Healthcare Linen episode. So with me, I have Alexander Sundermann. Alexander, welcome to Let's Talk Micro again.
Yeah, great to be back, Lewis. It's been a fun time. Always like talking about outbreaks.
What a pleasure having you. And so let's go ahead and start with some, what you've been here before, and it was last year. So maybe for all those new listeners, you can tell them a little bit about what you do and anything else that you want to share with them.
Yeah, so I'm currently an assistant professor at the University of Pittsburgh in our School of Public Health. But my research deals with using genomics and investigating hospital outbreaks. So my background was I originally started as an infection preventionist for many years in our hospital. Slowly transitioned. I did my doctorate of public health and epidemiology. And now I work on the research side of genomics and outbreaks, but all of our research I do is applied into our hospital where I used to work as an IP. So it's kind of come full circle, but it's been a great experience. And this paper that we're talking about today is really the culmination of the past 10 years of work that we've put forward to it.
Okay, so let's go ahead and start with what is, and it's abbreviated the EDSHAT. So what is the Enhanced Detection System for Healthcare Associated Transmissions?
Yeah, so it was a term that my mentor, Lee Harrison, coined whenever he first created the R01 NIH grant, uh, over 10 years ago. We call it EDS-HAT. So it's the Enhanced Detection System for Healthcare Associated Transmission. So whenever we were looking at, the issues of hospital outbreaks, one of the first problem was looking at how do we detect them. Traditionally for hospital outbreaks, we have to wait until there's a nursing unit or clinician that says we've had, 5 C. diff cases this week. That's strange. And then our IP team would go investigate. They would have to do all this manual chart review. They would have to, talk to the nurses. They would have to do all these hand hygiene audits and hands cleaning. And then maybe at the end, if it's available, not all hospitals have it, they would do genomics. And oftentimes we would find that it's not truly an outbreak. These pathogens, C. diff, were not genetically related. So, we spent all that time of like misallocation of resources. They spent all that time doing chart review. So, EDS-HAT is meant to be prospective genomic surveillance, meaning sequencing regardless of the suspicion of an outbreak. And we do bacterial genomics for this project. And then, in addition, what this project started out to look at too, as well, is could we mine the electronic health record using AI machine learning to automate the investigation of these outbreaks that were detected by genomic surveillance. So together, that's what we call this project, EDS-HAT, the Enhanced Detection System for Healthcare Associated Transmission.
Okay, and then when it comes, and you just touch on them, any other challenges that it comes, you mentioned that, you sometimes, you find that these organisms, they're not genetically related, and you have, you're spending all this time and resources, and any other challenges when it comes to outbreak detection?
Yeah, I mean that's the bulk of it, and we had a prior paper in the CID a few years back where it was kind of the proof of concept of EDSHAT, both the genomic surveillance and the AI aspect. And we designed that study so that we sequenced all of these pathogens and used our AI tool for 2 years without telling any of our infection preventionists. And in that 2 years, we found many, 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 many outbreaks. I mean, almost 100 outbreaks of about 300 patients or so spread out across the couple of years. So these were all outbreaks that were missed by the traditional standard infection prevention practice. So Lewis, in addition to what you mentioned, we often find inaccuracy of our current methods. What we think are outbreaks are actually not outbreaks, but we're actually missing lots of outbreaks that go under the radar in hospitals as well.
Well, and before I move on, and of course, this is a very dense topic. I'm just curious. Maybe you can just touch a little bit because you mentioned it about maybe about this AI tool. Just a little bit of whatever you can mention, and with the understanding, of course, that there's a lot of information in this, and we could do like many episodes alone on this. But I just want to do more of a curiosity thing. Can you touch a little bit on this AI tool that you're using?
Yeah, yeah. So it was built to once an outbreak is detected, it looks at what's in common among all of the outbreak patients versus everybody else in the hospital. To simplify it, it's kind of just like a giant case control study in a sense of it looks at our genomically related outbreak clusters with everybody else. And it shows us what could be likely routes of transmission for these outbreaks that are detected. And we did that in our prior retrospective analysis where we could just go back and use this tool in addition to, myself mainly reviewing the charts. That was in our prior paper. In this paper that we're talking about today, and for the past, it's been 3.5 years now, we don't use that AI tool in real time, mainly because of some IT barriers into getting it into what a real time tool can be. But in this paper that we're discussing today, it was just genomic surveillance and manual review. And I try to emphasize that now as well, because when other hospitals are trying to think about, can we do this? You don't need this AI tool. It's a nice to have, but the genomics is really where it's at for the laboratory perspective.
Okay, thank you for that. And we'll talk more about that in a little bit about the lab applications and bringing it to the lab. But let's go ahead and start talking about the study itself. And as I said, in the intro to the audience, I'll put the link on the show notes so you can read it and then see more details. So let's go ahead and start talking about the study. Like materials, the sample, and the procedure.
So yeah, like I mentioned, we had our prior paper with 2 years of sequencing. We didn't do anything, and we said, okay, this looks like we have good promise in what we could prevent. We're going to start doing this in real time. So we did 2 year analysis of real time sequencing. We're still doing it to this day, but we cut it off at 2 years. So essentially, what we did is for the some major bacterial pathogens that we see. If a patient had been in the hospital for 2 or more days, or had some recent healthcare exposure, develops a positive clinical culture from any site for one of these pathogens, we would every single week, twice a week, go down to our clinical lab, pick up those bacterial isolates, and then bring them back up to our lab, process them, get them ready for sequencing, do the sequencing, the bioinformatics. And then myself, each week from our bioinformatician, I would review what new outbreaks did we detect that week, what outbreaks are growing from prior weeks as well. I would review these patient charts to see what could be a common source, a common patient, and then notify our hospital's infection prevention team about this outbreak, where we think it's coming from, and then they would go into the hospital every week, do the interventions, the best practices that we know to stop this outbreak where we think it's occurring, and then continue to keep on monitoring. So we did that for 2 full years, every single week. And what the analysis, the methods came from is So, from our prior study, we knew how big an outbreak on an individual unit would get, an outbreak from a single piece of equipment would get. We used that data and we said, okay, when we make our interventions now in real time, how big are our outbreaks getting? And we looked at the difference and differences to say, how many infections do we think we prevented in the end?
Okay, so overall, so you did that, and then any right, like anything that you're doing, there's always challenges. While you were doing all this and the analyzing and the collecting the samples, what challenges did you encounter along the way?
Yeah, I mean, it's a Herculean team too within our lab that made this possible. And again, it's not without our IP team to be able to do it. So I mean, in the 2 years, we sequenced almost 4,000 bacterial isolates. So there was a huge effort from our laboratory and team, our bioinformatics team, about how to analyze that, how to go about it. And then our IP team had to think about the interventions. It's not always straightforward when we do these investigations, and there was a good proportion that we only found common links among our patients about 60% of the time, meaning we investigate these patients that are genetically related 60% of the time. It's very clear where the infections are occurring, what unit or what procedure. But that leaves, about a 40% time where we couldn't find anything among them that's common. So we always have to ask ourselves, what do we do with that data? But also, how deep do we have to look into these patient records that we're not finding any commonalities? At some point, we have to stop looking, right? So navigating some of those nuances were some of the difficulties looking into this.
Okay, so you said you're a 60% link, and then so what else can you share about the findings of this?
Yeah, yeah. So the big thing is what were the outbreaks that we found? So we found 172 outbreaks that comprised almost 500 patients. So you might be thinking, that's a ton. But what we try to emphasize is it's not necessarily the amount of outbreaks. Doing genomic surveillance and interventions prevents further spread of an outbreak. It doesn't necessarily stop the presence and establishment of an outbreak. And then additionally, whenever patients move around the hospital, we're doing our interventions where we think transmission occurred. Patients move elsewhere, and then they have the ability to spread it elsewhere that we're not doing interventions yet. So just because outbreaks are large doesn't necessarily mean that's a failure of what we did. So how we modeled our results is once we make an intervention, how many additional infections do we see? We saw that 95% of the time when we made an intervention, the outbreak stopped where we made an intervention. So that measure of effectiveness, although observational measure of effectiveness, was very promising. The other result that we look into is, what were the outbreaks? How were they spreading? In infection prevention in hospitals, endoscopes are very notorious for causing outbreaks, often large outbreaks. We ourselves were one of the first hospitals to discover that issue years back in the early 2010s. We used to have outbreaks of single endoscopes, 10, 20 patients large from a single endoscope. Doing this method, now we have two patients genetically related, same endoscope. We detect the outbreak. We remove that endoscope, make sure it's working correctly. We clean it an additional time. Sometimes we found issues with those endoscopes. We put it back into service. We saw no outbreaks above two patients related to a single endoscope. So observationally, we went from 10, 20 patients down to two patients. So we know that this is working from that data. And then the last thing that we tried to summarize is, the cost effectiveness. So we modeled that we prevented about 62 infections conservatively over those 2 years, prevented 5 deaths. Those are infections that are no longer being treated for in the hospital. And treating infections can become expensive. It's like $25,000. So even though we sequenced almost over 4,000 isolates, we prevented 62 infections. That's a net savings of about $700,000 net savings. So it's, we prevent infections, we prevent deaths, and we're actually saving money in the end.
Wow. So all of these are definitely some major outcomes. I would say very positive, right? Just starting by the saving lives alone. So anything else that you can share about any other thing that that maybe was considered like a major outcome or something positive that came out of this study besides all those things that you mentioned?
I think in our one table, we describe some of like the high impact or notable outbreaks. And, I think if this technology, not think, we know if this technology is used in other hospitals or other facilities, its utility will be exponentially helpful, because we at our hospital doing sequencing can detect outbreaks outside our hospital walls. So the one interesting outbreak that we had, or we detected, was an outbreak of 5 patients with Proteus mirabilis, uroseptic, as coming from a um, a long-term acute care facility or a skilled nursing facility. And these patients were being sent to us in our ER, and they were septic with Proteus. We sequenced them, and they were all genetically related. And again, since they came in from an outside facility, that was the only thing in common among them. So we notified this nursing facility and said, this is what we're doing. Here are the results. Here are the patients you sent us. You might want to look into this. When they looked into it, they were a ventilator facility. They found that the single-use filters on all their ventilators were never being changed among all of their patients, and that all these patients that were being sent to us were part of that group. So it acts as like a quality assurance measure for outside facilities as well. And then the other interesting finding that we found that we also published separately is that over a couple years ago now, there was the extreme drug resistant Pseudomonas aeruginosa outbreak that was linked to contaminated eye drops. So when we were reviewing our weekly outbreaks, I still remember we had these 2 patients that were sent to me, Pseudomonas aeruginosa infections, one SNP, single nucleotide polymorphism apart. One was, never an inpatient, a chronic outpatient person with this non-healing, serious ear infection, and another patient was in and out of a hospital from an LTAC, with a lot of comorbidities as well. Nothing at all common between them. So at the time, with the data we had, we said we have to move on from this. Months go by. The CDC announces, this large outbreak of contaminated eye drops. A couple more months go by. They share the reference genome of that outbreak. And I just say one day, let's run this genome against some of ours to see if we have a match. Those 2 patients were 0 SNPs apart, highly genetically related to this large scale national outbreak. We did a deeper dive on these patients' charts and found that one of those patients, that non healing ear wound, 1 month before their infection started, had ordered eye drops from Amazon, which was the implicated distributor, and used those eye drops on them and then developed this infection. It was the smoking gun that had these patients' infections. And that patient actually, publicly came out. There was a news article on them, underwent phage therapy because it was so drug resistant. So these patients, we can detect these national outbreaks just from looking at this genomic data. And we hypothesized that if other hospitals were doing this, this national outbreak actually might have been caught way earlier in its tracks than it needed to be. So those were other really interesting findings we had.
Wow, that definitely very interesting. And then I do want to check that you said that it was published about that patient that is went on to phage therapy.
Yeah, so we published our Pseudomonas eye drop um, outbreak investigation paper in JID, Journal of Infectious Diseases. There was a CNN article about the patient who underwent phage therapy. So if you're looking for that, yeah, I think CNN covered that article.
So when it comes to this, do you have any next steps planned or anything that's in the future for this?
Yeah, so I mean, we hope other centers will be able to replicate this, but it's a bit difficult to because it's kind of like the chicken or the egg of being able to get funding and being able to do it. Internally within our own health system, we're looking at trying to do an RCT or randomized control trial of interventions, but also expand to different facility types. Because where we did it at UPMC Presbyterian Hospital, we're a 600 bed acute care, tertiary care facility with does transplants and things like that. We want to try it out in a suburban hospital, in a community hospital, in a more remote hospital, in a children's hospital. These are all different types of facilities that we want to try to see if it works, and we want to do it in an RCT fashion that can show intervention effectiveness across different types of facilities. So I think that's where we're going to try to show it works other places as well. Um, but I hope other facilities can replicate this, because obviously, it can't just be a single center looking at this. But so far, some of the preliminary data, observational, retrospective data, all point in the same directions that this is a technology that will work in those facilities.
Okay, so and now as you have gone over the process, we have mentioned having other facilities, do this. Let's talk about this a little bit. And of course, you in this case, you were your samples you were analyzing them, so the clinical lab wasn't doing it. So that might not be an option, and maybe some other institutions, right, where it's just the clinical lab right there. So if a lab maybe was thinking of implementing this, what would you tell them? What do they need? Obviously, involves some communication between infection prevention, the lab, and so let's talk about that a little bit more.
Yeah, so before I get into there's a couple of resources. We have a preprint by our lab supervisor and lab director, Katie Waggle. It's on medRxiv. It goes into the nitty-gritty details of the lab processes, the operations, optimizing the laboratory processes to reduce costs. It goes into our bioinformatics tools, and they're refining some of that as well, but it's available on medRxiv. And then, additionally, we have a commentary in ASM, one of the journals there, AAC, where we go into, how could other hospitals implement this in a more broad perspective. It's called Pathogen Genomics: Overcoming Barriers and Future Directions. So those are sort of resources out there. But you're right, Liz. So we are a research facility who had these types of resources built up over many, many, many years. We have research techs who are experts in this. We have bioinformaticians who are expert in analyzing the data. We have the tools already invested in. So it's probably not feasible for that small community hospital. So in the future, we think it's kind of going to be a combination approach. You'll have some academic centers like us that might have the infrastructure already established that could run some of this. There are going to be hopefully some more investments into public health in the future on using genomics and having that as an availability. But also, I think a gap, and we mentioned this in our commentary, is that eventually there needs to be commercial solutions. Similar, like we see commercial partners make laboratory tests or laboratory machines for doing this types of things. There has to be some types of commercial solutions for those community and more isolated hospitals that's not going to have ready access to an academic center or a public health resources that are strained. And that's not quite there yet. But in the future, that's, I think, how it's going to become more readily available.
Yeah, I mean, definitely so. And yeah, when it comes to, like I say, with resources, and sometimes you have some very small labs where not even Molotov is there yet. It's like just so definitely the resources is very important. Okay, so this is a question, and then before we wrap up, I will ask you if you have any remaining thoughts, and if anything else that you want to add. But recently, kind of, I've been asking the guests this. It's kind of like a little fun thing, and we all have that organism, right? That maybe there's something interesting. Either it has some significance. Some people say, maybe they wrote a paper on it, or there's something about the morphology, or maybe a mechanism that they have, or they just bottom line they consider it their favorite bug. Do you have one?
So, it's I think it's been shifting. In our prior podcasts, we talked about, mucorales, and I originally liked those, but more recently, I've been really interested in non-tuberculosis mycobacteria. It's because I'm seeing through some of our own investigations and reading about others that it's probably a highly under-recognized bacteria for infection prevention. You can read some studies by Duke, really great studies on NTM and using genomics. And there's a hospital in the UK that kind of came out with it as well, where they're finding lots of outbreaks of NTM, NTM avium, abscessus, in their patients, that it's coming from their water. So we know water is not sterile whatsoever. So these folks at Duke and this other hospital in the UK have found, it's ubiquitous in their water. It's in all sources of their water, and they're finding it getting into their patients and causing very severe, difficult to treat infections in their patients. So as we kind of do some of our own research that we haven't published yet, and we hope to share soon, I feel like this is going to be, a hot topic in the future, because typically NTM had been just heater cooler devices or other types of equipment. But I think hospitals soon, as genomics takes off, are going to realize that NTM, we might have been underestimating it, more than other bugs in the past.
So this is definitely some very important work, and then you have shown the positive impact that this has, on the patients and many other things. So is there anything else that you want to add about this?
Yeah, it, where this was a research project, but at the same time, we were able to show translation into practice. So I've had the wonderful time to be able to share this with a lot of hospitals, a lot of institutions, through grand rounds or conferences or things of that nature over the prior few years. And I always say it's the easiest talk I ever give, because people like to see these results. They mainly agree with the results, but the questions that always come up is, well, how the heck are we going to do this? How are we going to pay for this? People will tell me that they go talk to their hospital administration and say, they just don't have the funding for it. And this is something that I've heard from everyone I've talked to. So I think the big challenge going forward is, how do we sustain and fund this type of technology at other different hospitals? And this is something that we've thought about for a long time. And I think the approach is going to be, an insurance approach. It's very unique here to the U.S. But the story that I try to tell in a similar fashion is that, in the early 2000s, late 90s, healthcare associated infection (HAI) reporting really didn't exist. But what the CDC and CMS did is they incentivized hospitals to report their HAIs by saying, if you report HAIs, we'll pay you money. Slowly over time to where we are now, you have to report HAIs if you want CMS funding. And if you're not at a certain threshold of HAI rates, you actually are penalized. So I think in a very similar fashion, we can potentially see insurance incentivizing hospitals to sequence covering those costs. So the hospital will actually, improve their patient safety. And in the end, the insurance companies save money because they're no longer paying for the treatment of these infections that are prevented. And I think that could be a sustainable funding model for the future. And of course, as we cover in our ASM paper, there's tons of other operational infrastructure issues that have to be addressed before we get there. But I think, ultimately, perfection is the enemy of progress. It's not going to be seamless as it rolls out across everywhere. But I think we have to have these hard discussions of, how do we operationalize it? How do we fund it? And not just say, this isn't possible at our hospital. It might not seem that way, but let's have some talks about how to actually get it implemented. I think that's going to be important moving forward.
I completely agree. And so, thank you for this. It has been so great. And I always love, learning more about things that happen, outside of the bench work, let's say, and what you're doing, right? Like we see something you mentioned, Proteus mirabilis, and something that's so commonly seen in the lab, right? And then thinking about some of the work that that goes outside and the impact that it can have with the patients. It's definitely great to learn and see that that you're working on something like this, and hopefully those challenges, we can overcome them and make this a more common application in other systems as well. Because a
Yeah.
lot of good.
Yeah, I had a great opportunity. One of the great talks I gave was actually to our own clinical lab because our clinical lab got to know our research techs in our lab and our research folks. And at the end of this analysis phase, we went back down to the clinical lab and we gave this presentation about what we found and what we prevented. And I really tried to emphasize to those folks in the clinical lab that they were the ones to help us prevent these infections and save lives. And we were so happy to try to show them that, like, because of what they did, they helped these patients. And that was a really humbling, great experience to give back to those clinical lab folks that because of them, this project was successful.
I love this. I love that how you did that, and that communication, that feedback. Yeah, that's excellent. So, as just as the last time, Alex, such a great episode and a conversation. So I appreciate you taking the time. And in the future, if you have any other topics, please feel free to suggest them. And the door is always open here at Let's Talk Micro. So thank you so much for taking the time.
So much, Lewis. This is great. Thanks for having me back on.
Well, there you have it. Great episode with Dr. Sundermann. And if you want to check out more of him, there was an episode, as I said at the beginning, that he did for the podcast, which was Healthcare Linens, Outbreaks, and More. And this was episode 169. But there is no doubt of all the positive things that a system like this, an outbreak system brings, and from, saving lives, saving costs, that early detection. There's so many positives. So hopefully, we can overcome the challenges of implementing something like this across all labs. As I said, there are so many positives. Okay, so as always, you can find Let's Talk Micro on any podcast platform such as Apple, Spotify, Amazon Music, Good Pods, and you can find me on social media and Instagram, TikTok, YouTube, and Blue Sky Social as Let's Talk Micro, on X as Let's Talk Micro 1, on LinkedIn as Luis Plaza, and there's an email address which is letstalkmicro@outlook.com. So either via social media or via email, you can reach out with any suggestions, any feedback. They are always welcome and appreciated. So please subscribe to the podcast, follow on social media, download episodes, and if the app allows you to do so, please go ahead and leave a review. Thank you so much. And if you are looking to learn more about antibiotics, please check out www.learnantibiotics.com and the Learn Antibiotics book, available on Amazon. These resources include cheat sheets, practice test games, and more, and they are being used by thousands of people worldwide and may be helpful for you or your colleagues. And these are some great resources from Dr. Timothy Gauthier, a very passionate pharmacist. And as you know, the Let's Talk Micro podcast does not have any sponsors, so if you want to support the podcast in any way, you can do so via a Venmo link or via Buy Me a Coffee, KOFI, both links available on the show notes. And as you know, the Let's Talk Micro podcast is supported by the American Society for Microbiology. To learn more about microbes, visit asm.org. And that, my dear audience, is the end of this episode. I hope you enjoy learning about this outbreak detection system. As always, I enjoy sharing this information with you. So please continue bringing that passion to what you do. It's so important. You do such great work. And hey, stay tuned. Great things coming your way. So I always appreciate your support. And hey, if you are in Los Angeles in June attending Microbe 2025, please stop by and say hello. I'm looking forward to meeting you, connecting with you. So, as always, stay motivated, stay safe, and of course, continue talking micro. Until the next time, bye.